Today I have a talk about pediatric and neonatal end-of-life emergencies, and by the end of the talk, I'll have just a few points of pediatric palliative care from my point of view as a pediatrician and a neonatologist that I would like to discuss. Just a few slides after that. But during this talk, I'll be discussing cause of death in infant and children. There are two slides I will go quickly over what are the major causes of death in pediatric population. Select CNS emergencies that can lead to death instantly, GI emergencies, cardiorespiratory emergencies, and acute kidney injury. And I know a couple of lectures ago, another fellow discussed those emergencies in adults. So I will not go over all details regarding those emergencies. I will just discuss. Oh, can you see me? Oh, okay, now it's working.
Yeah, we got your slides. We're good.
Okay. So I'm not going to go in details on all of those emergencies. I'm going just to mention the major differences between children and adults, and of course, some of those emergencies are not present in adults. And then by the end, I'll go over some few perils of pediatric palliative care from my point of view. So for infant mortality, as you can see, this is data from CDC up until 2022. And the major concern for infants, as you know, is uh, children under the age of 1 year old. The major reasons for mortality is congenital malformation, chromosomal abnormalities, genetic disorders. This is number one. Number two would be related to prematurity and low birth weight. I'm not going to discuss those today because those are very big chapters that take lectures to discuss, and usually they don't lead to emergencies long term. They will need long term hospice and comfort care, but it will not be considered as emergency. However, sudden infant death syndrome is number three in the causes, and accidents, unintentional injuries. Those are major, and very devastating to families when they happen to children or infants. And I've witnessed, unfortunately, all of these conditions, and it's really terrifying and even for the medical team. It's really heartbreaking. For the children, it's a little bit different, of course. Some still congenital anomalies will, of course, cause death in older children more than a year old, but that's not the main reason. The main reason is unintentional injuries. This is number one, accidents. Number two is birth defects, and number three is homicide. Cancer can cause it, of course, number four, and suicide is number five. But suicide is attributed to ages above five. Like, by the age of up to 5 or 6, usually the children don't have the capacity to understand the concept of ending their own life. Usually, it's more of if like a child had a gunshot, a father had a gun in their house, and the child 3-year-old hold it and accidentally discharged the gun against himself. It's not suicide, of course, but it's called unintentional injury. And unfortunately, I have seen those. So what are the CNS emergencies I'm going to quickly talk about? Number one is submersion or drowning, head trauma, and neonatal encephalopathy. So submersion injury. So this is the second most common cause of accidental death. Peak risk are children below 5 years of age, and usually there are two main reasons for those children to die: either fall in a swimming pool, and that's why it's a requirement in some states or almost all states that when you build a swimming pool, you have to have with children in the house, you have to have about 1.5-meter high fence surrounding the swimming pool, so you can avoid this kind of injury. Another thing is those, especially toddlers, can drown in buckets of water. Like if you have a bucket of water that you're using to clean or wash your car, for example, and the child is walking around, find it, try to play in it, and then whoop, the head is heavier, as you know, than the body. The head will drop in the bucket of water, and if nobody is around, nobody's noticing them. Unfortunately, the toddler will die from drowning, and it's unfortunately very common to see it. Second reason is child abuse, and we have seen it a lot. Uh, some parents will fill the tub with water, put the child in it, especially if it's hot water. They put the child as a form of punishment. It doesn't have to be intentionally to kill them, of course, but as a form of punishment, they would put a child in a tub of water and let them sit there. And if parents is not paying attention to the child, or parents are on drugs or alcohol, they are not paying attention to the child, also this can cause submersion injury and drowning. And the second peak age is about 15 years old, and this is due risk behavior. In adolescents, they have a concept of immortality. When you are 11, 12, 13 year old, usually they have thinking of, I'm not going to die. I can do anything I want. Nothing will kill me. And this can lead to risky behavior, not paying attention to currents, river currents, or riptides, or even you are not able to swim that deep, they can lead to drowning. Or of course, if a teenager or a college student is on drugs or alcohol, also can lead to this injury. Complication of the submersion injuries can cause, as you know, ARDS, CNS injuries from two things. Number one is if they fill in water, the body of water, if it's shallow and hit their head or their neck, can cause severe CNS damage and spinal damage too. And this actually spinal damage can lead to more. The child or the adolescent is not able to swim and get out of the water, which can lead to death. Can cause metabolic and aspiratic acidosis. Hypothermia is protective, so actually it's better to be near drowning in cold water than normal temperature water or lukewarm water. And the reason is hypothermia stops all anoxic processes in the brain that happens during drowning. For example, ATP consumption stops, free radicals of oxygen stops being produced, and all this is protective of the brain for a short period of time, of course, not drowning for a long period of time. And the body of water itself should be cold for this to happen, for hypothermia to be protective. And I've seen it multiple times. Most people that near drown or submerged in cold water survive more than normal temperature water. Primary care, primary thing to do to if somebody notices a person that is drowning is to get them off the body of water, start ventilation. So number one in children and mainly neonates also, and CPR is make sure the ventilation is correct, because this will solve about 90% of your CPR problems. So ventilate, protect the spine, of course, and place an NG tube to decompress and remove all excess water to prevent the patient from aspirating those. In freezing water. So if a person drowns in freezing water, when they come out, they will be blue. The temperature will be so low that a lot of people and some medical personnel will consider them dead. But actually, guidelines say that if a person that dropped in freezing water, do not consider them dead, and do not stop CPR until you get them out of the water, continue CPR until the body temperature goes back to normal, or at least is warm. Make sure that they are already dead, because we have seen it. Freezing water can cause change in the color, cyanosis, and temperature, of course, below that anybody would think, oh, this patient has already died. No, in cases of freezing water or very cold water, make sure that you warm the patient, put warming blanket, continue CPR until you are sure that it's this cold temperature is from death, not from being in freezing water. And of course, hypothermia causes bradycardia too, so it might be difficult to assess the heart rate at the time. If the patient is doing fine, is just swallowed some water, CPR was done and just expelled the water, you can observe you have to observe at least for 6 hours. You don't let them go home, because sometimes pulmonary edema will ensues later on. Electrolyte disturbance also will happen. So observe them at least for 6 hours in the emergency department. If they're doing fine, the child is playing, no respiratory distress, no asthma, no wheezing, nothing normal in the x-rays, you can send them home. And prognosis of the submersion injury depends a lot. In addition to the other factors that I mentioned, depends a lot on whether the patient is awake or not when you are talking to them. If the patient is awake, alert, or even responding to your touch, your painful stimuli, that's a good indicator that they will have better chance of survival. But if not, if with pain stimulus or touch or pain stimulus they are not responding, that's a bad omen. Next, head trauma in children. Most common cause actually is abuse. And usually, we always recommend to parents, and this is one of the things that we tell in our pediatric offices: do not shake the baby. Like some parents, when they play, and this is intentional, just intentional to play, nothing to hurt about the baby. Do not shake. You can hop up and down, but do not shake. Do not do the child back and forth, because this will produce cope anti-cope injury to the head. And usually diagnosed when some parents will bring a child and say, "Oh, I don't know what happened. My child just fainted. He's not responding." What to do? We do a CT scan, for example. We see some injury to the brain, subarachnoid hemorrhage, or epidural or subdural hematoma. When we suspect um, abuse, other than the history, nothing else can tell us if this is abuse or not, beside written hemorrhage. So normally, if it's just trauma from like if the child fell and hit the head, or had any other accidents, usually written hemorrhage will not happen. The shaking baby syndrome, this will cause written hemorrhage. So definitely one of our assessments for those children is to do a retinal exam by an ophthalmologist. And if there is hemorrhage, this is a very good indicator of child abuse. Basilar skull fractures from trauma can happen, and usually they will present with those signs. This will present with battle sign from like ecchymosis behind the ear or raccoon eyes. Ecchymosis below both eyes. Children can develop subdural hematoma from fractures or epidural even, and those are images of both the subdural hematoma. I think there's a concave shape. It's all since I was in elementary school, I was getting confused between concave and convex shape. But I know this is subdural hematoma and this is epidural hematoma. Pushing again is the brain, and this goes with the convex of the brain. And then we have the Cushing triad, which is an important indicator of increased intracranial pressure. It is bradycardia, hypertension, and irregular respiration in children. And lastly, a mild form of brain trauma called concussion, which can happen especially in athletes that practice football or basketball. Um, Concussion, they will present with vomiting, disturbed consciousness, and tachycardia. Usually, in order to decide whether this concussion to be treated in the hospital, observe it, or inpatient can go home, we have developed something called Pecan low risk criteria. If the Glasgow scale is above 14, there is no signs of fracture, no vomiting, no loss of consciousness, or severe headache, the patient can go home, can be observed at home, doesn't have to be observed or admitted to the hospital. And then we have neonatal encephalopathy. It's a syndrome defined with disturbed neurologic function in the earliest days after birth, in infants born after 35 weeks of gestation. Manifests by subnormal level of consciousness or seizures, and often accompanied by difficulty with initiating and maintaining respiration and depression of tone and reflexes. There are many, many reasons or causes for neonatal encephalopathy in the NICU, namely metabolic syndromes like urea cycle defects, infectious diseases, meningitis, thromboembolic like neonatal stroke, which is very rare compared to adult stroke, but it still can happen. Intracranial hemorrhage, which is very common, especially in premature babies, genetic disorders, or hypoxic ischemic encephalopathy. The most common one and the most dreaded form of encephalopathy is the last one, the hypoxic ischemic encephalopathy. So what happens is with the hypoxic ischemic encephalopathy is there is a sentinel event. Sentinel event mean something that happened just around labor time, either just before labor or during labor time. An event that lead to hindrance or delay or impedance of blood supply to the fetus through the placenta, such as the mom herself had a shock, was on a motor accident, placental separation or abruption happened, cord prolapse, or cord even avulsion sometimes. All these events will lead to a diminished blood supply to the brain, which can cause brain anorexia. When this event happens, the child responds by having metabolic acidosis, by having irregular breathing, and by having other signs of neonatal encephalopathy. So we have developed a staging system for HIE called Sarnat staging. And it is divided into 3 stages: stage 1, stage 2, stage 3, and severity. Stage 1 is the mildest form, and usually every aspect of exam would be normal except a little bit of changes. Like, for example, the suckling reflex, when you put a finger in the baby's mouth, will continue to suckle. Sorry, will be weak, and baby will have tachycardia, will have some dilated pupils, but will not have seizures. And usually the EEG is normal. And those babies are blessed that their prognosis is 100% normal. And usually they don't need any treatment. They don't just need some observation, like a 24-hour observation, then can go back to the mommy. Stage 2 is a moderate form. Usually the baby is lethargic, start to develop hypotonia. Tendon reflexes at this moment still active or active. They are not depressed yet. Myoclonus in babies can still present, which is sometimes can be normal. The reflexes start to weaken, like suckling and molar reflex. And then we'll have bradycardia, constricted pupils, and we'll start to have seizures. Usually with this mild form, where the baby is still responding, still have active tendon reflexes, usually 80% of those babies will be normal, and 20% of them will have moderate risk for long-term deficits. The most severe form is stage 3. The baby will be stuporous, flaccid, will have decerebration, no reflexes at all, have variation in his autonomics, like pupils are unequal, heart rate is variable, and will have seizures. It's sometimes seizures is not as common as the stage 2, but it's still present, and will have breast suppression on EEG. Unfortunately, with those babies, 100% of them will have severe sequelae even with treatment. So what is the treatment? So basically the rationale is similar to what I mentioned in submersion injury. The rationale is similar. It's to reduce cerebral metabolism, reduce ATP consumption, and gene activation. These processes lead to initiation and progression of brain injury. Once you freeze the baby, cool the baby's body and the brain, all these processes will stop, will not advance. Oxygen free radicals also will not be produced, which also contributes to the brain injury. What we have found with therapeutic hypothermia is it reduces mortality and disability at 18 months, especially with type 2, with stage 2 SUNET. What are the criteria to do hypothermia? First, number one, the baby should be born not less than 36 weeks of gestation. If it's a extremely premature baby, this doesn't work on them. Low Apgar score at 5 minutes. I'm sorry, at 10 minutes, less than 5. The pH, severe acidosis, pH will be less than 7. Base excess will be minus 16. And patient has seizures or signs of encephalopathy. What happens is we have a cooling blanket. There are 2 types of hypothermia, either head hypothermia or total body hypothermia. What you use, and most centers use, is total body hypothermia. With a cooling blanket, we'll put the baby on, we'll turn off the lights, everything that can cause heat. We cool the baby down to a core temperature of 32.5 to 33.5 Celsius for about 72 hours. And after that period of 72 hours, we start rewarming the baby, but slowly too also, so we don't activate the processes that can cause brain injury. And we rewarm for about 1 day until we reach core temperature of 36.5 Celsius. And usually by stage 1, of course, doesn't need hypothermia, but if you have suspicion, you can use it on stage 1, of course. But stage 2 and stage 3, you definitely need to use those. But it works better if the baby only has stage 2. And this is HIE is one of the dreaded diseases or emergencies in the NICU and the OB/GYN, because most complications happen on the OB/GYN side rather than the NICU side. Usually it happens pre-labor or during time of labor. Okay, then moving to the GI emergencies, I'm going to talk about select ones, 4 ones actually. Malrotation, biliary atresia, intussusception, and bilirubin toxicity. And all 4 of these can lead to death. Okay, so malrotation. So what is malrotation? So normally, I don't know if you can see the picture pretty well or not. I think it's a little bit hazy, but normal rotation, that the gut with the stomach will come almost in the middle, a little bit to the left, and the small intestine will be exactly in the middle with the colon surrounding. That's normal rotation of the gut. With the malrotation, this doesn't happen for the small intestine and for large intestine. Small intestine will be placed on the right side of the child and the large will be on the left side of the child. And this can cause constrictions, can cause volvulus, where the intestines twisted on its own, and it can cause intestinal obstruction. Usually they present in the first few days of life, most of the babies with bilious emesis. So bilious emesis is one of the symptoms in our NICU world where we don't ignore at all. Even if it happened once, we have to check the baby, we have to do imaging, we have to make sure that the baby doesn't have any intestinal obstruction, mainly malrotation. Abdominal X-rays films are non-specific because you just see air gas pattern, but doesn't tell you where the small intestine, where is the large intestine. The gold standard is to do a contrast study, and this is a contrast study. As you can see, there's a stomach filled with this, a little bit of a study, the duodenum, and then all the small intestine is located to the right. It should be going all over the abdomen here, but all the small intestine is concentrated to the right of rotation. This is a case of malrotation, and this can cause bilious emesis. If not discovered early, can cause intestinal obstruction and intestinal necrosis, sepsis, and can lead to eventually, unfortunately, death. Treatment is basically gut decompression initially, but has to be taken for surgical correction within 1 or 2 days maximum. Intussusception. This is also a unique condition for children that can happen due to even acquired invagination of the proximal bowel, which is called intussusceptum, by peristalsis into the distal bowel. Oh, I have put a picture, but it looks like it's for some reason it's gone. Basically, the proximal bowel, instead of being one tube, I don't know. Let's see. Okay. So basically, instead of being the bowel being one tube, continuous tube, no, the proximal bowel will do something like a bird peak, and will go into the distal bowel. And this invagination will impede the blood vessels between those two parts of the bowel here in the middle, will impede the blood flow and can cause bowel ischemia. And if this was not reduced very ASAP, this can cause also necrosis and sepsis and death too. And usually the child will present with what we call as red currant jelly stool, basically red jam, exactly look like it with almost no stool. Usually, if there are many reasons for bloody stools in children, like dysentery, micral diverticulum, many reasons. But the intussusception itself will come without stools, and there's a difference between it and other reasons of bloody diarrhea or bloody stools. So we pay attention very good to this. Treatment is very easy. It's just reduction by an enema. Can be an air enema, just blow air there, so the invaginal loop will be pushed back, and this will go back to normal. Or sometimes we can use the barium enema itself that is used for diagnosis, can also help in fixing the problem. So the enema can be both therapeutic, diagnostic, and therapeutic at the same time. Biliary atresia. This is also a surgical emergency in neonates. It's frequently clinically confused with a more prolonged unconjugated hyperbilirubinemia. Because cholestatic jaundice is predominantly pathologic, distinguishing cholestatic versus non-cholestatic jaundice is critical. Everybody knows the normal physiologic jaundice that comes to babies, but both are yellow in color, but a little bit deep with the cholestatic jaundice, but both are yellow in color. So it might be difficult a little bit to distinguish. So it's really important to get total bilirubin and indirect bilirubin to make sure that it's not pathologic cholestatic jaundice. Children with biliary atresia have associated cardiovascular anomalies, GI anomalies, and malrotation and spinning. So it's not only that we need to make sure that biliary atresia is diagnosed, so we avoid liver cirrhosis and biliary cirrhosis, but also because it's associated with other anomalies. It's really important to diagnose. Efficient diagnosis of biliary atresia is critical toward the goal of reestablishing bile flow via Kasai hepatic portoenterostomy. So basically, we take a part of the intestine attached to the liver, open a pathway for the bile to go to the intestine, just to relieve the obstruction. Unfortunately, the only other cure is to get a liver transplant, but it's really difficult to do, to have the opportunity to do that, to find that donor. Next item is the bilirubin toxicity, which is used to be known as kernicterus. Kernicterus itself is the clinical entity, but the big picture is called bilirubin toxicity. So it's acute bilirubin encephalopathy, yellow staining of the brain, generally involving basal ganglia, cranial nerve nuclei, and hippocampus. As you can see here in the image, this is the basal ganglia. Is stained yellow. If you compare it to the other matter of the brain, it's very yellow here. Staining correlates microscopically with necrosis, neuron loss, and gliosis. So it's not just a dye, but also has a huge grave effect on the brain development also. So this is a picture of the baby with kernicterus, unfortunately in the stage. They of course will come with jaundice, hypotonia, lethargy, poor feeding, poor suckle, and the cry. First, after a few days, the baby first will develop hypertonia, oxytonus, which is the arching of the back that you can see in the picture, high-pitched cries, fever, and seizures. Later on, the hypertonia will be replaced by hypotonia and long-term neuron injury. If the baby survives this and doesn't die from the brain insult, unfortunately, we have seen it happen. It's very rare to happen here in the US. And the reason is we are very strong and very aggressive against treatment of indirect hyperuremia. But I've seen it outside the US. Surviving children with kernicterus develop one of the following. They develop extrapyramidal disturbance, chorioathetosis, sensory neural hearing loss, gaze palsies in the eyes, dental height dysplasia, and mild intellectual deficits. Actually, it's interesting that it doesn't cause problem with the intellect. It causes more of motor deficit, motor development abnormality. But the first week is the most dangerous one because the brain insult can kill the baby. Next, we'll move to cardiorespiratory emergencies. I'm going to talk about air leak syndromes, pulmonary hemorrhage, congenital diaphragmatic hernia, sudden infant death syndrome, congenital heart disease, mainly hypertrophic cardiomyopathy, PDA dependent cyanotic lesions, long QT syndrome, and pulmonary hypertension. And all of these conditions can cause innocent death if not fixed emergently. So pneumothorax, I mean, I know everybody knows about pneumothorax, but I'm just talking from the point of view of a pediatric or neonatology. Air between parietal pleura, line with chest wall, and visceral pleura. Risk factors are aspiration of blood, meconium, and amniotic fluid. Lung disease, including that can lead to pneumothorax, meconium aspiration syndrome, RDS, pulmonary hypoplasia, congenital diaphragmatic hernia, and pneumonia. Main reason for pneumothorax in infants, especially neonates, is the high ventilator pressure. So that's why when babies are born, we check the X-ray first to make sure that they are not born with pneumothorax. So some conditions they have congenital pneumothorax from a blip that ruptured during birth. From the stress of birth, baby cries, start to increase intrapulmonary pressure and the intrathoracic pressure, and then this blip rupture. So first we take a picture and then we put the baby on a ventilator or a CPAP mask. Usually those pressures can be very high, if not calculated very well, and can lead to pneumothorax and bilateral. Actually, babies can happen bilateral. As I mentioned, spontaneous pneumothorax can happen in 1 to 2% of healthy full-term infants, often asymptomatic. But most cases of pneumothorax will happen in premature babies because of underdeveloped lungs. They presented with respiratory stress, cyanosis, apnea, and bradycardia. If it's severe, affected side will have decreased breath sounds with increased anteroposterior diameter. If under tension, if it's a tension pneumothorax, will have cardiorespiratory compromise. We'll have the bradycardia and bradypnea or apnea. There is an increased risk of intraventricular hemorrhage that happens with pneumothorax. This is a chest X-ray. As you can see, normal left lung. I mean, it's not completely normal. Like this is RDS. You can see the lung field is very hazy on the left side, but I mean, there is no pneumothorax on the left side. On the right, you can see this is the lung pushed away by the air. Oh, this is air. So what we need to do is put a needle and aspirate. So diagnosis is basically clinical. When I have a baby that was breathing normally on a CPAP mask, for example, and suddenly baby start to become cyanotic, bradycardic, or tachying first, and then brady, if the baby is, this will lead me to think about pneumothorax. Number one to do is transient illumination. But of course, different diagnosis with an X-ray. But if your transmission is good and you are sure it is pneumothorax, go ahead and aspirate. You don't have to wait for the X-ray. If it's essentially pneumothorax, you have to aspirate it. If it's a closed pneumothorax, you have to do some additional steps. You have to decrease the PEEP, decrease the pressure inside, decrease the PEP, decrease inspiratory time, so less air will enter the lungs, and increase the respiratory rate so you can get rid of the air very quickly. If there is no underlying lung disease, like a full-term infant that came with pneumothorax, mild, small size, does not cause cardiac compromise, you don't have to do anything. Do not aspirate. Usually just observe for 48 hours until the pneumothorax is spontaneously absorbed. But if, and usually absorbed within 48 hours. But if it's not, or it's getting bigger, or it's causing compromise, or if the baby is under mechanical ventilation, you have to aspirate and put a chest tube. Next one is pneumomediastinum. Usually occurs in healthy infants or infants with RDS, pneumonia, after resuscitation in the delivery room, or can be caused by direct trauma to posterior pharynx or airways. I have seen a baby that had an NG tube. The baby was 27 weeks of gestation. It was very tiny baby. Had a NG tube put in the nose, passed down to the stomach, and then after an hour, we found out the baby was compromising. When we did the chest X-ray, he had a huge pneumomediastinum. We thought it's because the baby is premature. It could happen, but we did a lateral film and we could see the NG tube passing, like going like next to the spine of the baby. So what happened is there was a big esophageal perforation from the NG tube that caused pneumomediastinum. Majority is asymptomatic. Usually, pneumomediastinum does not cause major cardiopulmonary compromise because it's wide, like it's a whole chest wide space. It's not enclosed space like the pleura. But sometimes can cause cyanosis, can cause muffled heart sounds. And we'll have the X-ray for pneumomediastinum. Pneumopericardium, this is the dreadful diagnosis. Usually, what happens is the air will dissect in the pericardial sac. And usually this happens most commonly in neonates when you have an umbilical venous catheter that goes from the umbilical vein to the right atrium. And instead of just staying there, suddenly or accidentally being pushed inside, pierces the right atrium and causes a hole in the heart, which can lead to pneumopericardium and also pericardial effusion and cardiac tamponade. If there is air under tension, pericardial tamponade will, with acute circulatory collapse, evident by decrease in pulses and increased pulse pressure. Symptoms dependent on level of tension and include cyanosis, muffled heart sounds, hypotension from inferior vena cava compression, and decreased cardiac venous return, leading to decreased stroke volume. This is the main issue with the. This is a very dreadful diagnosis and has a very high mortality rate. The reason is sometimes it's not caught fast, especially if it's a effusion, because effusion will be surrounding the heart. You will think it's just a heart shadow that's big. But, and we had a baby that like that, that was compromising. We did X-ray, nothing is showing. And the X-ray, except the normal, like a bit of heart shadow. We did a repeat X-ray after 2 hours, and the heart shadow was so big. So we suspected to be pericardial effusion from UVC, umbilical venous catheter, that went through the right atrium and punctured the heart and went into the pericardial sac. What we did a quick echo, confirmed diagnosis, so we aspirated this and the baby survived. So this is the imaging for both pneumomediastinum and pneumopericardium. On the left, you will find the pneumopericardium, and on the right, you will find the pneumomediastinum. The major difference, and this is a very important point, is that with the pneumomediastinum, there is no air below the heart because mediastinum is surrounding the heart. Here is the pericardial sac firmly attached to the heart and to the diaphragm. So there is no space for the air in the mediastinum to go around it. Unlike pneumopericardium, because it's in the pericardial sac, air is all around the heart. I think that striking differences here. Next is pulmonary hemorrhage as a result of an acute increase in capillary hypertonic pressure, which is secondary to left to right shunt from PDA or vasoconstriction following perinatal depression. Pulmonary hemorrhage can happen. And there is increased pressure that leads to capillary vessel breakage and large amount of fluid leakage. What are the risk factors? PDA is very well known to cause this, sepsis and left ventricular failure. Baby will present or child will present with bloody tracheal secretions, respiratory stress, cyanosis, and cardiovascular instability. Management is to increase the alveolar end descending pressure because this will cause the alveoli to distend and compress the capillaries where the blood is coming from. So this will decrease and impede pulmonary blood flow. Also assess for clotting factors and administer blood products as needed. Most of the time, it's not a blood problem; it's mainly a chest or heart problem. And treatment is treatment of the cause, but unfortunately, not a lot of babies survive this. This is a very poor prognosis. And there's a picture of pulmonary hemorrhage, as you can see. It's not different than pneumonia or RDS. It's all all white lines. You cannot see. Only difference is blood coming out of the mouth, or if baby has entered in ETT tube, will be coming out of the ETT. Congenital inflammatory hernia, another emergency, whereas there is herniation of intestinal content in the chest. As you can see here, this air is abnormal. It's loculated air. It looks like intestine inside the chest. And the heart is pushed to the right side, and you cannot see the lung on the left here. You see all this is intestinal loops. You cannot see the lung in here, and you can see the heart is pushed away. This is severe form. Usually the lung will be hypoplastic, which is the most dangerous thing because the lung is not well developed and baby will eventually die from it. Mortality is very high. Mortality is 20 to 30% if cases of diaphragmatic hernia. Clinically, baby will come in distress, will come with a scaphoid abdomen because the intestine is not in the abdomen, so abdomen is empty, will be scaphoid, and you can hear bowel sounds in the chest. But actually, this condition can be diagnosed easily prenatally. So by the time baby is born, we are ready to manage. So what is the management? Number one is to immediately intubate the baby. Never, never, never put a bag and mask on a baby with congenital diaphragmatic hernia because the air you're pushing to the nose and mouth, half of it will go and all of it will go in the intestine because, as I mentioned, the lung are hypoplastic. So there is a huge pressure in the lung will prevent air from flowing inside. So all the air will go in the intestine, which will go to the stomach, which will eventually go to the intestine, which will compress the lung more, compress the heart more, will worsen the condition. So number one, immediate intubation. Even if the baby is doing fine, you have to intubate him, even if the baby is bleeding. Number two is bowel decompression to get rid of the air. Sedation to decrease pulmonary hypertension because one of the main reasons of death in those babies is pulmonary hypertension. We need ECMO until surgery is done and then surgical correction within 24 hours. Outcome prediction, how can you predict the prognosis of this condition? By something called lung to head ratio. The chest is bigger than the head. If the chest gets smaller from pulmonary hyperplasia, it's because of the congenital inflammatory hernia. Sudden infant death syndrome. I'm sorry, I'm trying to go fast because I don't want to be late because I know I should end by 8:30. Sudden infant death syndrome, SIDS. This is a dreadful condition also for the parents and the family and the medical team. Sudden infant death syndrome is a sudden death of an infant less than 1 year of age that remains unexplained after a complete internal review, which includes full autopsy, examination of death scene, and review of clinical history. Make sure that 100% this is not a case of child abuse, this is not a case of unintentional injury, this is not a case of a disease or a condition that was not diagnosed prenatally and just the baby died. It's a third leading cause of sudden death in infants. Rate has decreased since implementation of safe sleep strategies. We tell the parents to put the baby on their backs when they are asleep, never sleep with the baby on our chest, and don't put any towels or toys around the baby so they don't fall on the baby while asleep and suffocate the baby and cause death. Risk factors, of course, is prematurity because the baby is very tiny, they don't cry a lot, and they are very bendy, so they don't have the muscle tone and strength that can prevent this from happening. IGR is similar to this. Winter months, because in winter people tend to wrap babies in a lot of clothing, which can cause also sudden infant death. Secondhand smokers was found a good correlation between that and SIDS. Young maternal age because awareness, education, just being young itself, taking care of a baby can be very overwhelming. So unfortunately, this is very common to happen in young maternal age. And of course, history of prior sibling with sudden infant death means that the other sibling also can have it, the new sibling. So we watch those very carefully. Congenital heart disease incidence is 8 in 1,000. VSD is the most common lesion in pediatrics, and TEJ is the most common cyanotic lesion in the first week of life. So what happens with TGA? And this is, I'll mention the important points only. So what happens is the aorta, instead of coming from the right ventricle, comes from the right. I'm sorry. Aorta, instead of coming from the left ventricle, comes from the right ventricle, and the vice versa for the pulmonary artery, comes from the left instead of the right. So what happens is blood coming from the body through the vena cava to the right ventricle, and then goes to the aorta of the body. So blood will be deoxygenated. On the other hand, pulmonary artery coming, the blood, oxygenated blood will come from the pulmonary veins in the left ventricle, come back to the pulmonary artery to the lungs. So those will act as two separate cycles or connections. They are not connected to each other. So the oxygenated blood will always be oxygenated, deoxygenated will always be deoxygenated, and the patient will die. The only thing that keeps them alive is connections, either a VSD, an ASD, or a PDA. What's important in this lecture, what can kill a patient is the PDA. If the PDA is present, this will allow mixing of blood between the right and left side, which can give some oxygen to the baby. Saturations are usually like 70%, which is good, despite it being cyanotic, but that's not bad. So this will allow the baby to survive this PDA connection. What happens is normally after birth, this PDA is closed because of many reasons. When this closes, there is no connection between two circles, and the patient will eventually have cardiogenic shock and die. So what happens is, if we have a baby that's cyanotic, we do immediate echo. If the echo shows a TGA with the PDA open, we have to keep this PDA open. We had a situation in the NICU, baby was born outside and came cyanotic for many hours. And this was the problem. The PDA was closing. We had to start prostaglandin right away, keep it open, and send them to surgery to either do a Rashkin to open like to create an ASD for the patient to allow mixing, or put like a coil inside the PDA to keep it patent rather than just medicine. So this can cause sudden death. We had another situation where I had a patient with articulation of the aorta, in which this distal aorta will be narrow, so also will have no blood supply to the rest of the body. Only thing that can make the baby survive is a PDA. I had a baby that was 2 months old, came in cyanotic heart failure. People thought first, for some reason, he was having pneumonia or bronchiolitis, was treating him with antibiotics, but the baby got worsened, started to develop heart failure, cardiogenic shock. We did an echo, and it turns out to be this condition, coartication with the PDA almost closing. So start him on prostaglandin right away and send him immediately for surgery. Another condition that can cause sudden death is hypertrophic cardiomyopathy. It's an autosomal dominant disorder due to a haphazard arrangement of myofibrils lead to hypertrophy of interventricular septum. The most common cause of sudden death in athletes. About 4 years ago, it was a very well-known case of Sparrow, a college student at MSU football team that suddenly fainted. Was brought to the hospital. By the time he arrived to the ED, he was dead. Autopsy showed that he had hypertrophic cardiomyopathy and caused him arrhythmia, and he died from it. Treated with beta blocker and restriction of activity. And definitely, those patients that have hypertrophic cardiomyopathy should abstain from strenuous sports like competitive sports. They can play, like they can run, cardio, heavy lifting a little bit, but not strenuous or competitive sport. And of course, myomectomy need to be done. How to diagnose it? It's more generally asymptomatic, but you can hear a systolic murmur at the sternal border, and Valsalva maneuver or standing worsens the murmur. And the reason is venous return will decrease with standing, and this will make the murmur worse. Will lead the ventricle will not be dilated enough to push the blood, and will make the murmur worse. So we can differentiate it from the AS, from aortic stenosis, because this can kill. Aortic stenosis, at least when it's not bad, doesn't kill, but this one can kill, and unfortunately we have seen it. Okay, long QT syndrome, another one that can cause sudden death in children. It's an inherited disorder that causes prolongation of QT interval that can advance to VTAC or VFAB. Corrected QT interval more than 460 milliseconds is diagnostic, and is because one of the being cause of sudden death in children. Treatment is by beta blocker and implantable devices. This is the EKG. As you can see, Q and until the T is very long. It's about 2 big squares, which is very, very long. And usually what happens, how diagnose it? Usually there is a family history of sudden death, and then the parents will come and tell us this, we have to do an EKG. Any history in the family of sudden death in children or pediatrics, we have to do an EKG. This is number one. Pulmonary hypertension. It's failure of decrease in pulmonary vascular resistance after birth, attributed to airway obstruction, inflammatory conditions such as sepsis, pulmonary hypoplasia, such as, as we said, in congenital diaphragmatic hernia, or babies with oligohydramnios. There is not enough amniotic fluid running around the baby, which will cause the lungs will not be distended, which will cause pulmonary hypoplasia. And maternal medications also, indomethacin and inhibitors of prostaglandin will cause pulmonary hypertension, such as aspirin. What happened is there is increased pulmonary vascular resistance, will lead to right to left shunting. Blue blood will go to the left blood, to the red blood, which causes cyanosis and hypoxemia. And usually, infants usually present within the first 24 hours of life with severe cyanosis and respiratory distress. As we said, this will cause severe hypoxemia and labile oxygenation, meaning if the baby cries, his oxygen will drop. If the baby is touched, the oxygen will drop. This is one of the signs in the NICU that would tell us, oh, this baby is having pulmonary hypertension. Usually it's a single or narrow split sound, loud S2. And if the ductus is present and there is minimal AV shunting, then the preductal sats will be higher than the postductal sats, which we call as differential cyanosis, which means that the baby's right arm will have normal stats, but the left arm and both legs will have lower saturations. Acute kidney injury. Causes are prerenal, renal, and postrenal, similar to adult, but the important point about children than adult is prerenal cause is more common in peds than adults. It is due to decrease in effective renal blood flow due to severe intravascular volume loss from hemorrhage, for example, or GI loss, diarrhea, and vomiting cause acute kidney injury, acute kidney failure. And some children might need dialysis for that. Renal artery stenosis, heart failure, and liver cirrhosis. Drugs, NSA, gentamicin, and vancomycin. And very notably, we have seen it a lot, that babies that are given a dose or two of ibuprofen will start to have low urine output. Gentamicin is interesting because there is a gene that if it's absent in or mutated in an infant or a child, one dose of gentamicin, only one dose, is enough to cause acute kidney failure in this child with this abnormal gene mutation. So it's really important to watch and monitor the kidney function to children taking NSAIDs, gentamicin, or vancomycin. And finally, in high school footballer, rhabdomyolysis with a myoglobin release from the muscles will obstruct and will obstruct the kidney tubules and cause acute kidney injury. And we see it a lot. Treatment is just give a lot of fluids and to induce diuresis and get rid of all the myoglobin. Okay, I only have 9 minutes. Okay, a few points of peds palliative care from my point of view as a pediatrician and neonatologist I'd like to talk about. Number one is uniqueness of pediatric palliative care. What's the difference between adult and peds? Number one is different epidemiology. We have different diseases. We have different physiologies. We have different, like in adults, very rarely you will encounter a problem with congenital defect or a genetic disorder. But those are very important to know, very important to understand, very important to acknowledge in a child, different epidemiology. Various span of developmental stages. So when you talk to a child that is 3-year-old is different from one that is 10 years old, different from one that is in high school or college, completely different. So it needs specific skills to know what to tell each child or how to tell each child. A broad array of rare genetic syndromes and different physiologies. I mentioned that. Complex family structure. Usually in adults, when we have an encounter, you have the wife, maybe children. But with the children, as we have seen, its siblings are involved. Parents, of course. Grandparents are involved. Daycare, nanny, if the patient has a nanny, pets. So it's not only one or two people are affected by the children illness, but a lot of people are affected by it. Need for age-appropriate developmental informed communication skills, loss of anticipated normal life. Parents, when they hear that they have a baby, they start to have dreams and anticipations with child future. Will be an astronaut, will be a doctor, will be a football player. Parents have dreams about their children. So when a baby is born with a congenital anomaly or a birth defect, or a child even diagnosed with cancer or leukemia, this is devastating. This is destructive to the parents. This even gives the parents a feel of guilt that what happened to my child is because of me, especially with birth defects or congenital anomalies or genetic anomalies. Parents feel guilty all the time that I gave this to my child, so I'm responsible for this. Ethical and legal issues, of course, because you are dealing with a child. You have to have a who is the guardian, who's taking care of the child, who will be taking care of the child if the parent died. Oh, it went away. Let's see. Do you the screen's gone, right? Oh. Oh, okay. I don't know what happened. Sorry.
No worries, it's back.
Yep. Let me go back. Okay. Okay. Less use of long-term care facilities and hospice, as we know. We don't have in Lansing area, at least, any long-term facilities for children. Different modes of dying. As I mentioned, unintentional death, homicide, birth defects, all of these are devastating to the families, and less ability or willingness to discontinue therapies. It's very difficult for parents to tell you, yeah, stop treating my child, or stop doing the NG tube, let him be dehydrated, let him not eat. It's very difficult. Like, even when I started to do my palliative care fellowship, when I had the first encounter with an adult patient, that it transitioned to comfort care, and then they said my attending physician said, "Oh, we'll discuss with the family that we will not give feeding anymore because the patient is dying." I was like, "Oh, how can this happen? How can you uh, deprive a patient from eating?" But now, with my training, I understood why we're doing this. But in a pediatric population, it's really an issue. It's not easy. It's if you tell a parent that we're not going to feed your child because it's dangerous for them, they cannot understand this. Or even don't give fluid, they cannot understand this. So it's another dilemma. Siblings, and this is overlooked a lot in peds and the ICUs in general, in peds or NICU. Siblings often forgotten during crisis time, like during patient or a child that was unintentionally dead or had an injury. Yeah, parents are screaming, everybody's losing their minds, but we forget there is other children that are brothers and sisters for the deceased. They cannot believe it too. They have been playing with them. They are the person most involved in the patient's life. You forget about this all the time. They are most affected by the tragedy. Children tend to either express their grief or ignore it completely as a coping mechanism. Some are uncomfortable to witness the parents' distress, and like they might be able to, okay, my brother died, I understand, but whenever I see my parents keep crying, keep remembering my sister or my brother, this is uncomfortable to me. I cannot live with that. Should keep the routine. One of the advice we give to the parents: do not stop. If your child died today and his sibling has a daycare the next morning, send your kid to the daycare. If you promise him to go to the movies, do that. Do not stop routine, because you don't want children to feel that the tragedy itself is affecting their life, because it can have bad impacts. Can affect their education negatively or positively. Some children will take it on their own, on their chest, and will be depressed like adults, which can be understandable. Some other will say, no, my parents are sad. I have lost my brother, for example. I will do my best to the perfect person to serve the community and serve patients like them. And this happened with me when I was a child. I had a brother that died from pneumonia when he was an infant. And this is one of the reasons why I decided to join pediatrics and neonatology. So, but it can affect negative. It could be negative also. It can make me feel depressed. I don't want to live. I don't want to do anything anymore. School counselors can help, and child life specialists also can help. Help siblings during the time of the tragedy or death. Another point is non-pharmacological pain management in pediatrics. There are 4 things we can do: developmental interventions, physical, sensory, and psychology, and sensory intervention. Developmental interventions. Number 1, empower the child to choose family or friend for care team. When you have a child that with terminal illness, cancer, for example, they might be not comfortable with a parent or a sibling or a grandfather or an uncle. You should ask the child, who do you want to be in the room? Who do you want you to be during the procedure? Who do you want not? Who don't you want not to be present when this happens? Honest, developmental, appropriate information. You have to tell the child, the 3-year-old, that he's dying. How? There's a communication skill that need to develop and to be trained well. It's really difficult, but you can explain it to them. And here comes a child life specialist rule. In our life, in Spiro, our child life specialist, they have in their tablets, they have stories and animations to explain to the child what this means, either to the patient himself or the siblings. It's beautiful ones in the sense that it explains it and makes it easy for the tragedy that child is going through. Physical intervention, positioning, how the child is sitting, whether the parent is hugging them, sleeping on bed, what is a good position for the child. Swaddling, this is one of the effective methods in NICU. If you want to poke a baby to get an IV line and you want them to cry, swaddle them very well when they feel they are tight and they are swaddled. This brings back the memory of being in the womb, which make them very, very comfortable and very happy. Kangaroo care or skin to skin contact, like here. This is a very premature baby on a CPAP mask, and the father is holding him to the chest. This improves temperature regulation, improves breathing, and this is like evidence-based medicine. I'm not just saying from experience. It's evidence-based medicine that improves temperature and improves respiratory condition and blood sugar, also blood glucose levels. And similar to here, this baby is not sick, just born newly, but I put both pictures together. Buzzy Bee. This is, I don't know if you guys saw it or not, but this is a device that is used while you're giving injection to the child. This blue part is just a freezing cold, you know, uh, compress, like it's silicone or something that is freezing cold, so can decrease the pain. And this bee is buzzing because causes vibrations also to eliminate the pain. And believe me, we have done it. We have tried it, especially in the ER and Sparrow. Children feels very, 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 very minimal pain, very minimal. Sensory intervention, unlike adults, art, music, aromatherapy. In babies and neonates, oral dextrose, sucrose 12% solution. This is evidence-based medicine. This has a similar effect to giving ibuprofen to a baby. If you want to sedate a baby, I'm sorry, you have analgesia for a baby for a short period of time, like you are doing an IV line, or you are preparing for a procedure and you want the baby to cry or get upset, oral dextrose, and you put a little bit on your finger, gloved finger, you put it in the baby's mouth, or on a pacifier. Excellent, works perfect. You don't have to give any medications at all. You don't have to give Tylenol, Ibuprofen, or even morphine for a very short period of time. It only lasts for up to 8 minutes. Psychological intervention, distractions, breathing exercise, and visual distractions. So I have a video. I think this is my last. Yep. I have a video about the distraction that a physician can use to distract, or a specialist can use to distract a child from the procedures happening. For example, like shots. Let me see if I can share it. Can you see this video or not?
Yes, yeah, we can see it.
Okay. So this is a baby in a pediatrician office and getting shots to his thighs. So I don't know if you saw it before or not, but it's very quick. It's less than a minute. Yeah.
1, 2, right. 1, 2, right. Good. Daddy's got your arms. Whoa, we don't like this. Was that a 1, a 2, right? Good. Yeah. Is it 1, a 2, right? Good. Yes. We need tissues. Yes, it's your band-aid. Good. Look at your band-aids. What's that? Let's get this one on. You're going to take it right off. I know you guys. Take them right off. What they do is say, good. All right, clean up. Everybody finished.
So yeah, as you can see, the shots, like if anyone of course, like you guys have children, you have been to pediatrician office. Unfortunately, not everybody does this, but you can see with the shots, babies cry a lot. So distractions are really important as a psychological intervention to do with patients for small procedures or even for pain. Visual distractions on an iPad or a TV or a lava lamp, sometimes like any toy. This also helps pretty well with the pain intervention, pain management in babies or children. It doesn't have to be always medications. Thank you so much.
Excellent, excellent. Excuse me. You can go ahead and stop sharing now so we can get folks back and see if there are any specific questions or comments. I think that it just really, I have a tremendous amount of respect, for you and you and Brad and Shiraz and Matt and those that are regularly on the call here who are engaged in pediatric care. And sort of, I admit to having just a little bit of PTSD from when I used to do pediatrics, and just really appreciate the background that you have in doing this, and appreciated the linkage that you provided there at the end in terms of the relevance to palliative care. Some of us will never have the opportunity to take care of kids, but many of us will from time to time, depending upon the area in which we work, especially if we're in the hospice work. We'll occasionally have opportunities to see these kids, and I just appreciated your perspective on that. Any questions or comments for Mohammed?